Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Avalada from Roots Community Health, reporting for the week of June 9th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut the noise and bring you the latest information on health issues relevant to us all. After an update on COVID, measles, and pertussis, I will share some more concerning developments from the federal government related to the present and future of public health. First, taking a look at respiratory viruses among patients that present to a healthcare setting and get tested there. And as of the end of May, the largest share of cases is by far made up of rhinovirus enterovirus, which is that gray line. And we see that has been the largest share for the past couple of months now. To a much lesser extent, we're seeing parainfluenza virus in the yellow, followed by human metapneumovirus in the black, which seems to be going down in terms of its share of cases. And then fourth is SARS-CoV-2 in red. Although, as we've said here, I think it's safe to assume that a large portion of those folks with SARS-CoV-2 are actually finding out on a rapid test that is not necessarily going to be reported here. So in order to get a better sense of where things are with SARS-CoV-2, we can look at some of our other early indicators. So taking a look at SARS-CoV-2 in the wastewater, we can see that wastewater viral activities are low or very low in those pale colors across the majority of the country. But over towards the west there in Oregon, Nevada, Arizona, it is moderate, and it is considered very high in Alaska and Louisiana. And the number of wastewater sites in each state does vary quite a bit, so you can check out the link in the post if you're interested. But for example, here in California, there are 71 different wastewater sites reporting. So if you want to get an idea of how things are going around you, you can check out wastewater sites in your area. And this graph is taking a look at the United States in bigger regions. And so the United States, instead of by state, we're looking at 4 big regions, but it does give us a sense of the direction that things are heading. So here we can see that the West, which is depicted by that teal line, we can see that SARS-CoV-2 in the wastewater is heading up for the Western region and looks pretty flat in the other regions. So we'll just keep an eye on that. And taking a look at the map of COVID epidemic trends, which uses modeling, and this is based upon emergency department visits for COVID, and this helps us see what direction things are heading as well. And we do see that while most of the country is in gray, meaning that it's not changing, some places are increasing. In the lighter purple, we see California, Hawaii, and Maryland, where COVID-19 is believed to be likely growing. And then in the darker purple, where it looks to be growing, is DC, New Mexico, and Florida. And now taking a look at COVID deaths, there have been 250 deaths recorded so far for the week ending May 10th. The week before that, the week ending May 3rd, there were 10 more deaths added from what I had reported last week. I reported 267 deaths, but we now see that there are 277 deaths for the week ending May 3rd. And we do expect that as additional death certificates come in, but this is a significant milestone that these 2 weeks represent. And that is an all-time low of deaths since this all got started in March 2020. In fact, these are the only 2 weeks since the pandemic onset that we've had fewer than 300 deaths in a week. So still too many, but hopefully we'll continue to see it come down. And in the meantime, we'll continue to keep an eye on those early indicators that we just reviewed so that we can do our best to prepare and hopefully avoid a repeat of what we experienced last summer, which was a very significant wave, including more than 1,000 deaths per week for a couple of months. And of course, we do that. We prevent these deaths with timely testing and treatment, as well as vaccination. And this includes a second COVID vaccine. So that's 2 per year, at least for those who are 65 and up or immunocompromised. So we had a wave this past winter, which was not as large or as deadly as the one last summer. We have SARS-CoV-2 circulating all year round. but we do seem to be seeing a pattern of 2 waves per year, typically winter and summer, although we have had surges in different seasons, but lately it has been pretty much winter and summer. And that in itself is unusual. Not sure that we really have a great explanation for this. We have thoughts about it, but no real explanation. We know that to some extent, increases in cases are driven by our behavior. So increased mixing and traveling, which we know is higher during our summer break and our winter holidays, when we tend to mix and travel and fly, along with other types of mass transportation. But I do think we really need to learn more. We need to really assess the strategy where we are urging people to get vaccinated around the same time as the flu vaccine every year, even though SARS-CoV-2 doesn't follow the seasonal flu pattern. And if we were to judge by last year, we might actually think that now would be a better time to get the vaccine than in the fall. But we know that, again, our behavior may drive some of these patterns. So I really don't think we have a solid answer on any of this. Regardless, we know that the vaccine is really only giving us a few months of protection from catching SARS-CoV-2. That's different from protecting from the severe outcomes, which last longer, but we also know tapers off, especially for those at highest risk. But either way, the annual vaccine strategy itself is going to continue to fall short. And so we basically don't have a real handle on all of this or a great way to predict or prevent so many tens of thousands of deaths every single year. And it's possible that when we tell everyone to get vaccinated around October, November, then we're preventing a big surge in the winter. But then by the time we get to this time of year, enough of the population is once again vulnerable. And so we get hit hard like we did last summer. And then, of course, add that to the fact that last year, so many people got COVID in the summertime, add that to the group that got vaccinated in the fall. So all that to say that it could be that we just had more protection over the winter months because of that. But then again, that's going to leave the population more vulnerable now at this time of year as SARS-CoV-2 continues to circulate and increases in circulation as predicted over the summer. So bottom line with this is, first off, if you're 65 and up, or you have immune compromise, or really any underlying condition, or even any exposure risk that makes you concerned, then I think this is a great conversation to have with your medical provider. If you don't have one, please get one. We are in a better situation this year than prior years in that we're not waiting for a new vaccine formula to be dropped in September like we have for the past few years. It's going to be the same formula this year as last year. And so it will presumably just continue to be available. Now, the only exception to that is if you're waiting for the new Moderna formulation that I reviewed in some detail last week. That is currently specifically approved for those 65 and up and those with underlying conditions. It's a more targeted vaccine, seems to be just as effective and less reactive. So if this is something you're interested in, check out the briefing from last week. But if this is the route you're wanting to go, then you may indeed need to wait a bit because it's not available yet. For everyone else, I think if you're going to be staying on a once a year cadence, then we need to understand that, again, the protection from catching SARS-CoV-2 is going to be short term. And so when is that ideal time to get it? And I do not think we have a true answer to that question. Ultimately, we need a better vaccine. We need a more long-lasting vaccine, more variant-proof, all of those things. But until then, I do think this is worth talking over with your provider. Maybe your annual vaccine should be timed differently based on your own patterns when you may be engaged in more high-risk activities, and also based upon when you or if you last had COVID. And along those lines, I do still think it's worthwhile to pay attention to what's going on around you, be aware of what's going on where you are or where you may be traveling to. And so that when cases are starting to rise, we can think about our protection accordingly. And now for an update on the U.S. measles situation. As of June 6th, there are 1,168 total cases. And this is up from 1,088 a week ago, so an increase of 80 cases in a week. Last year, the entire year of 2024, there were 285 cases. So already in 2025, about 5 months through, we've had more than 4 times the number of cases we saw the entire year of 2024. Also, in these first 5 months of 2025, there have been 3 deaths. This is as many as we've had in the past 24 years. So definitely not headed in a good direction. As we head into summer break, remember that airplanes and airports are high-risk locations with a lot of mixing. So wearing a high-quality filtration mask is an important layer of protection. Of course, the most important layer of protection by far as it relates to measles is going to be the vaccine. So if you're not protected from measles by either having previously survived it or through having had the 2-dose vaccine series, this is something very important to do in general, but especially before traveling, not only to protect yourself, but also to not be that person who starts a whole new outbreak in a whole new area, because we know that that is really what all it takes. And remember, the 2-dose vaccine series is given 28 days apart. Then it takes another couple of weeks before you build up your immunity, so that's 6 weeks. So please start planning if this applies to you. And we can give the vaccine as young as 6 months of age. So if you're going to be traveling with a baby into an area that's having outbreaks or into a part of the world that has measles circulating with a baby under 1 and over 6 months, then you are going to want to give that additional vaccine. So please check in with your doctor or travel clinic. Now, last week, I talked about some concerning developments as it relates to the federal government's approach to vaccines and vaccine guidance. I went over that in some detail. So if you're interested, check out last week's briefing. Bottom line there is that there are a number of discrepancies and mixed messages, as well as circumventing established public health advisory processes that are all a great cause for concern. And I'll talk more about that, about more developments there in a moment. But first, here's another concerning development resulting from other public health recklessness that I wanted to share specifically as it relates to measles. And that is regarding the Global Measles and Rubella Laboratory Network, GMRLN, affectionately referred to as Gremlin. This network is the one that essentially tests and monitors measles and rubella globally. So testing, sequencing, and so forth, and monitors for outbreaks. I linked a great article about this from Stat News in the Post. But this network is made up of 760 laboratories around the world. And some of these are national labs, regional labs, and so forth. And in fact, this is said to be the world's largest laboratory network. And this network has been funded by the CDC and run by the World Health Organization. So a collaboration there. And without the CDC funding, it is on the verge of falling apart. So this is just another example of how the US withdrawing from global health, from the World Health Organization, is having major ripple effects. And really the amount of money needed to sustain this is pretty much a drop in the bucket in the grand scheme of things. It costs about $9 million a year. So it wasn't just that the financial support ended, it was how abruptly that happened and how we are just sending scientists and public health people scrambling here at home and all around the world, and how this has real impacts. So without a transition plan, now the World Health Organization Foundation is out there raising funds to try to fill the gap. I find it pretty concerning that it appears as though we are going to try to rely on philanthropy to fill a critical gap for what really is a public health concern. And no foundation really has the ability to fill these kinds of gaps. Even Bill Gates came forward previously to say that the Gates Foundation cannot assume the role of the government and that we need an actual viable plan. But because this particular gap is a relatively small gap in funding, there's hope that it can be patched by philanthropy, at least in the short term. Still, one major concern, like other things we've seen with these abrupt changes and withdrawal of funding, is that during all of this upheaval, many of the labs could lose their capacity to test, which is very concerning because measles shows up as a rash and a fever, and if you don't test, you're not going to be completely sure. And so we're going to lose, or we're at risk of losing a comprehensive view of what's going on in the world as it relates to measles, which is bad for all of us. And especially right now, when even the United States is having outbreaks, let alone the other places in the world. And with us doing more poorly than we have done around measles in decades, we are certainly just as much in need of this kind of global surveillance as anyone, because we are making ourselves more vulnerable by having dropping vaccination rates. And similarly, we are seeing increases in pertussis, and sadly, 2 unvaccinated infants have died from whooping cough in Kentucky. This marks the first such deaths in the state since 2018. Both of the infants were unvaccinated. The mothers were also unvaccinated. These were vaccine preventable deaths. So pertussis, aka whooping cough, aka 100-day cough, is a highly contagious and potentially life-threatening respiratory illness. It's particularly dangerous for babies, but it can affect anyone. The health officials in Kentucky are urging what we all should be urging, which is maternal vaccination as well as infant vaccination. The series for that starts at 2 months of age. And officials do expect cases to rise through the summer to the fall, so we'll be keeping an eye on this. But it does seem to be part of a very sad and really disturbing trend where we are allowing the resurgence of vaccine preventable deaths among our children. So it's very hard to reconcile claiming to be all about the children and making the country healthy again when we are significantly backsliding on something so basic. And in more concerning news, RFK Jr., in his role as HHS Secretary, has disbanded the Advisory Committee on Immunization Practices, ACIP. This is the advisory committee to the CDC, stating that this move is intended to restore public trust in vaccines. So he claims that the ACIP has been plagued with persistent conflicts of interest and has become little more than a rubber stamp for any vaccine. So experts and medical associations are already coming out to voice concerns. I'm certainly concerned that this drastic move, given RFK's known skepticism of vaccines, will destabilize established public health processes and actually deepen the distrust in vaccine science. And maybe this is the point. If he's truly concerned about conflicts of interest, then I'm very curious as to what steps will be taken to address this for the future. So I have watched many ACIP meetings. There's a whole section in the beginning where people declare any conflicts of interest that they may have. I've even heard them declare the ones that aren't really conflict of interest, but maybe perceived conflicts of interest, like they're working on, they're a lead investigator in a study about a virus, but not a vaccine. And we know that they are to recuse themselves if a vote were to come up on anything that was an actual conflict. So I haven't seen an abundance of these conflicts. There are some that do get declared, which is good. In fact, most of what gets declared gives more credence to these individuals as actually being experts and actually being in the field. I put a link in the post to past ACIP meetings and what conflicts have been addressed in those meetings so that you can see for yourself. And I haven't yet seen anything detailing how this process will be changed or improved in the future if this is truly a real concern. So I'm sure you can find people with zero conflicts, but let's please not get people with zero expertise. And I'm, of course, concerned about that because this has been a pattern so far, putting unqualified individuals in positions of authority over health and public health in this country. And it is truly frightening and kind of getting more frightening by the day. RFK Jr. says he wants people who are not afraid to ask the hard questions. And I have to say that I don't know any scientist that's afraid to ask hard questions. That's literally what is done in science. But to be clear, asking hard questions in and of itself is no special skill. Anyone can ask questions. Anyone can ask hard questions. What we really need to know is, can you answer the hard questions? So do we have the expertise and the experience in the room to answer the hard questions? So I will certainly be watching with interest to see who is appointed. Are they going to be nominated? Or what is the process going to be? How will the supposed conflict of interest issues be overcome? And I'll mention too that there are experts banding together to create kind of unofficial advisory bodies, and I will plan to touch on those in a future briefing. And hopefully we will have some kind of counter to counter what thus far has been a lot of ideology and conjecture and gripes rather than any kind of real science. So in the meantime, let's continue to stay informed and to advocate for maintaining access to good information, to good care, to appropriate vaccination. Remember that as we are heading into summer, we do anticipate seeing more COVID. We're already starting to. So remember that if you don't feel well, take at least 2 COVID tests 24 to 48 hours apart to rule out COVID. If you're positive and at risk of a bad outcome, quickly get in touch with your primary care provider to get treatment. If you don't have a primary care provider, please get one, develop a relationship with them, make a COVID treatment plan if appropriate, and just in general, make sure that you're getting the appropriate labs and screenings and vaccines based on your age and risk factors. Try to eat a balanced diet, stay well hydrated, quit smoking, limit alcohol, simple sugars, processed foods, and artificial ingredients. If you don't feel well, make sure you get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you next Tuesday at 10 a.m.